Hello dear friends, how are you doing today? I hope you are doing well. Today we are going to talk about nevus or mole. Definition: a nevus or mole is a benign neoplasm or pigment-forming cells, the nevus cell. Nevi are congenital or acquired. A junctional nevus is macular with nevus cells confined to the base of the epidermis. Compound and intradermal nevi are popular with nevus cells in the epidermis and dermis and in the dermis only, respectively. Here we can see compound nevus. Even border and surface brown pupil are characteristics of compound nevus. In epidermis, we can see pigmented nevus cell nests in the lower epidermis, and in dermis, we can see pigmented nests of round nevus cells in upper dermis. Bundles of spindle-shaped nevus cells in the lower dermis is present. Types of nevi include junctional nevus, compound nevus, and intradermal nevus. Incidence: nevi should be considered a normal skin finding. The average number of nevi per person is 2 to 11 for black people and 15 to 40 for white people. Data from a large prospective study of dermatological practice indicates that among melanocytic nevi removed by dermatologists, 40.7% were excised for aesthetic or functional reasons, 13.3% solely to reassure the patient, and 29.7% because the lesions were considered suspicious by the dermatologist, typically due to change in color, size, or irritation, and 21.5% because they were considered precursors to melanoma. History: most nevi are acquired after 6 months of age and before the age of 35 years. Thereafter, one sees a progressive decline in number, so that nevi are infrequent by age 80 years. Moles usually appear singularly, rarely in crops. It is common to have darkening in color, itching, and development of new nevi during pregnancy and adolescence. Otherwise, symptomatic nevi should be regarded suspiciously. Physical examination: nevi vary greatly in appearance and coloration. However, individuals tend to have similar appearing nevi that are generally uniform in color, surface, and border. The pigmented lesion that differs from other nevi or the ugly duckling should be biopsied to rule out malignant melanoma. Nevi are flat or elevated, smooth or verticoid, polypoid or sessile, and pigmented or flesh colored. Their coloration is orderly with shades of brown and occasionally black or blue, although the later colors should be regarded with suspicion. Skin lines may or may not be present. Nevi frequently contain hair. The junctional nevus is a light to dark brown macule. Compound and intradermal nevi are flesh-colored or brown, smooth or rough surface pupils that occur in older children and adults. Key points: nevi generally have uniform color, surface, and border. Changing or symptomatic nevi should be viewed with suspicion, and the ugly duckling mole should be biopsied. Uniform color, surface, and border are characteristic of a nevi. The ugly duckling nevus, the one that looks different from the patient's other nevi, should be biopsied. Differential diagnosis: the most important task is to differentiate a nevus from a malignant melanoma. Regular brown color, surface, and border are characteristic features of a nevus that differentiate it from melanoma. A junctional nevus may appear similar to other pigmented macules, such as a lentigo or freckle. Compound and intradermal nevi, when flesh-colored, can be confused with a skin tag, basal cell carcinoma, and neurofibroma. The presence of telangiectasia and central depression, as well as a recent acquisition in an adult, is characteristic of a nodular basal cell carcinoma. When pigmented, these nevui can resemble seborrheic keratosis and dermatofibromas. The presence of scale and passed-on appearance is atypical of seborrheic keratosis. Dermatofibromas are hard dermal papules that dimple when pinched, whereas nevui are soft. The spes nevus of benign juvenile melanoma is composed of spindle and epithelioid nevus cells. It is a smooth, round, slightly scaling pink nodule that occurs most frequently in children. The most important aspect of dealing with this lesion is to recognize that it is a nevus and not a melanoma, and to avoid extensive surgical intervention. Blood nevui are small, still voluminous papules and nodules that usually begin early in life. The importance is diagnosis in their similar appearance to nodular melanoma. If any doubt exists, biopsy should be performed. The dysplastic nevus or atypical mole is both controversial and confusing. Controversy exists regarding its propensity to develop into a malignant melanoma. The confusion stems from differing histologic criteria for diagnosis. Clinically, the atypical mole is more than 5 mm, is variegated in color with a pink background, and has an irregular, indistinct border. Atypical moles were initially recognized as markers for increased risk of melanoma in family members with inherited malignant melanoma. The familial atypical mole and melanoma syndrome or dysplastic nevus syndrome. In these families, virtually all members with atypical moles develop a melanoma in their lifetime, whereas family members without atypical moles did not. Subsequently, investigators discovered that approximately 5% of the healthy white population in the United States has atypical moles. The risk of developing a melanoma in these individuals, many of whom have only one or a few atypical moles and no personal or familial history of melanoma, is unclear, but for most, a melanoma never develops. We can see dysplastic or atypical mole, which is pink, tint brown, irregular shaped papule with an indistinct border. Congenital nevui are present at birth or shortly thereafter. They are usually elevated and have uniform dark brown pigmentation with discrete borders. Of newborns, 1% have congenital nevui. Large congenital nevui with more than 20% centimeter across or covering 5% of body area have a 6 to 12% chance of developing into a malignant melanoma. Small congenital nevui have little to no increased risk of transformation into melanoma and therefore do not need to be removed prophylactically. Here we can see congenital nevus, which is a black plaque containing dark hairs. Here we can see also congenital nevus. Laboratory and biopsy. Nevus cells vary in morphology depending on their location in the skin. They are arranged in nests in the basal layer of the epidermis and upper dermis. When they extend deeper, cord-like or shed-like formations occur. In the upper dermis and epidermis, the individual cells are epithelioid in appearance with a cuboidal or oval shape, indistinct cytoplasm and a round or oval nucleus, and are pigmented. In the middle dermis, nevus cells are smaller, do not contain pigment, and have a lymphoid appearance. In the lower dermis, they have a spindle cell appearance resembling fibroblasts. Immunohistochemical markers can be used to identify melanocytic lesions. Atypical moles histologically have abnormal architecture of melanocytes within the epidermis, a dermal fibrotic response, and, depending on the pathologist, variable cytologic atypia. Therapy. The prophylactic removal of nevi is not required, whereas some lesions are those that have changed in color, shape, or size, have been acquired in adulthood, bleed, or are itching. An excisional or deep shave biopsy with narrow margins with 2 to 3 mm is recommended for suspicious lesions. Clinically benign and cosmetically unsightly nevi may be removed by shaving off the lesion with a scalpel. However, a superficial shave biopsy leaves some residual nevus cells at the biopsy site that may become darkly pigmented. The management of congenital nevi is difficult when these lesions are large with a diameter more than 20 cm or covering 5% of body area, and somewhat controversial when they are small. Large congenital nevi, such as the bathing suit nevus, cover extensive areas of the trunk in a garment-like fashion and are generally associated with many satellite lesions. They are rare but have a significant potential for developing into malignant melanoma, which is 6% to 12%. At the least, patients should be followed carefully with excision or nodules that develop within the nevus. Large congenital nevi covering the head and neck are sometimes associated with underlying meningeal melanosis, seizures, mental retardation, and development of meningeal malignant melanoma. For small congenital nevi, no excision is needed unless the lesion changes clinically. The optimal treatment is excision of the lesions, although the technical difficulty for removing such wide areas of skin may preclude this therapy. The recommended advice to the healthy person with multiple atypical moles but no personal or familial history of malignant melanoma is patient education about sun exposure, self-examination, and yearly full skin examination by a physician. The conclusion of therapy for nevus, the initial therapy include shave biopsy or deep shave excision for worrisome lesions, and alternative therapy include elliptical excision. Note: all nevi that are removed should be examined by a pathologist. Course and complications. Approximately 50% of malignant melanomas have associated nevi. The relative risk of melanoma increases as the number of nevi increases. That is, persons with large numbers of nevi have a greater risk of melanoma than do persons with a few nevi. No evidence indicates that mild irritation or rubbing results in the transformation of a nevus into a melanoma. Some nevi develop surrounding the pigmented zone and are referred to as halo nevi. They occur singularly or multiply, usually on the trunk, in teenagers. The development of a halo around the nevus is a harbinger of its disappearance. Both humoral and cellular immunities appear to be involved with the development of halo nevi, a process that results in the destruction of nevus cells. On rare occasions, the pigmented halo develops around a malignant melanoma. If the central lesion has a uniform brown color, typical of a nevus, a biopsy is not necessary. Here we can see a halo nevus, which is a red tint brown pupil with a surrounding white halo. Note: halo nevi are rarely a malignant melanoma. Pathogenesis. Nevus cells are derived from the neural crest. Morphologically, one can recognize the nevus cell because it has no dendritic processes and groups together in nests within the epidermis and dermis, as we can see here in this histology. Clinical case. A 25-year-old man presents for a routine skin check. He has had a small brown lesion on his upper back or for as long as he can remember. It has not changed significantly in size or color. The lesion is asymptomatic. On examination, there is a 3 to 5 mm uniformly brown, slightly raised pupil with smooth borders. Dermoscopy shows a symmetrical pigment network. The lesion is firm but not hard, and there is no ulceration or bleeding. Which of the following is the most likely diagnosis? A. Junctional nevus. B. Compound nevus. C. Intradermal nevus. D. Seborrheic keratosis. And E. Malignant melanoma. According to our explanations, the diagnosis here is, or the correct answer here is, B, or compound nevus. Explanation: a compound nevus has both epidermal or junctional and dermal melanocyte components. Clinically, it appears as a slightly raised, uniformly pigmented pupil, often light to dark brown, and is common on the trunk of young adults, and is symmetrical stable for years, and usually less elevated and less dome-shaped than intradermal nevi. Differential diagnosis: junctional nevus is a flat macule, uniformly brown, often in childhood, and intradermal nevus is a dome-shaped, often skin-colored or lightly pigmented, and seborrheic keratosis is a waxy stuck-on rough lesion, and malignant melanoma is asymmetry, border irregularity, color variation, and evolution are the features of malignant melanoma. Okay, this was an explanation about nevus or mole. Thank you for your attention.